Okay, the last part of chapter 18, we're going to talk about some urinary system disorders. As per usual, for this section of the book, we're not going to go into vivid detail, but we're just going to briefly talk about them. We're sort of going to go from least horrible to most horrible, from, more common to less common, we'll say. And then at the very end, we'll talk about PT recommendations for urinary system disorders. So, same learning objectives. Urinary tract infections, UTIs, very common. Urine is an excellent growth medium. Lower urinary tract infections include cystitis, which is a bladder infection, and urethritis, infection of the urethra. Upper urinary infections include pyelonephritis, and they're frequently caused by E. coli from the other excretory system of our body because they're close. So that's a pretty common thing. They're more common in women because we have a shorter urethra and the proximity to the anus. Older men because of prostatic hypertrophy and urine retention. Congenital abnormalities in children can have an increased urinary tract infection risk. And other common predisposing factors include incontinence, urine retention, and direct contamination with fecal material. So they are more common in the elderly, and they can have more widespread and dangerous effects. So cystitis and urethritis are sort of the most external. The bladder wall and the urethra are inflamed. It causes hyperactive bladder and reduced capacity. So increased urgency and frequency. Pain is common in the pelvic area. So dysuria, painful urination, urgency, frequency, and nocturia, urinating at night. Systemic signs like fever, malaise, nausea, and leukocytosis might be present. The urine often presents as cloudy with an unusual odor. You may recall that I talked about a nurse that I used to work with in the skilled nursing facility who could detect a urinary tract infection by odor just because she had smelled so many of them. Urinalysis to diagnosis usually indicates bacteria, pyuria, and microscopic hematuria, which is inclusion of blood in there. So bacteria, pus, and blood indicate the infection. And usually they do culture and sensitivity and figure out which drug is going to kill it. So that's what we want to do. We want to kill the bacteria. Pyelonephritis is where one or both kidneys are involved in the infection from the ureter into the kidney. So the purulent exudate can fill the pelvis of the kidney and the calces. Recurrent or chronic infections can lead to scar tissue formations and loss of tubule function. So that's a problem because we know how important those kidney tubules are. So like I said, we're going to go from least bad to most bad. So we're headed down the road. Recurrent and chronic infections causing the scar tissue formation can also cause obstruction and collection of filtrate, which is called hydronephrosis, or like water on the kidney, if you want to think of it that way. It can lead to chronic renal failure if untreated. So that's not good. That's not good. Let's treat that. So signs and symptoms, signs of cystitis plus pain, dull aching pain in the lower back or flank area. That's a pretty vague symptom, right? That could be a lot of different things. So interesting. Systemic signs can include high temperature. Urinalysis is going to present as similar to cystitis. Urinary casts are present, which are the little inclusions, and those little solid inclusions, and that's a reflection of renal tube involvement. That's the difference between pyelonephritis and cystitis. And it's treated with antibacterial agents. Usually they do a culture and sensitivity to see what's going to kill their particular bacteria. Acute renal failure can be caused by lots of things. Can be caused by acute bilateral kidney disease of any type. It can be caused by severe prolonged circulatory shock or heart failure. It can be caused by nephrotoxins like drugs, chemicals, or toxins like paint or solvents or that kind of stuff. Disinfectant, the stuff we're disinfecting the gym with. Mechanical obstruction can occasionally cause acute renal failure, like calculi, which are stones, blood clots, tumors, which block urine flow beyond the kidneys. That's never good. Usually with acute renal failure, there is sudden onset. It is diagnosed by blood tests. You see elevated serum urea nitrogen and creatinine levels. Usually you'll see serum urea nitrogen as blood urea nitrogen, and it's BUN on the blood test. You'll see elevated BUN and creatinine. Metabolic acidosis and hyperkalemia also show up because of the function of the kidneys and keeping those normal. It has to be treated by identifying and removing the primary problem. So we saw all those things that could cause it. You have to figure out what's causing it and fix that. So all those things, you got to fix that. You want to treat it ASAP to minimize the risk of necrosis and permanent kidney damage, because that's not good. Sometimes in a case of acute renal failure, they will do sort of temporary dialysis. They'll do just a few times to normalize body fluids and maintain homeostasis. And I've seen that in acute care a lot in the hospital. People are in the hospital for acute renal failure for various reasons, and they do just a couple sessions of dialysis to maintain homeostasis. So it's not necessarily a long-term thing for acute renal failure. Chronic renal failure, on the other hand, it's gradual, irreversible destruction of the kidneys over a long period of time, and it's asymptomatic in the early stages. It may result from chronic kidney disease, congenital polycystic kidney disease, which is one of those delayed fatal phenotypes where you don't know you have it until it's already too late. Systemic disorders, low-level exposure to nephrotoxins over sustained periods of time. So that's not good. The stages of chronic renal failure, first you get decreased renal reserve. So there's a decrease in glomerular filtration rates and higher than normal levels of serum creatinine, but no other clinical symptoms besides that. When you get into the stage of renal insufficiency, so that's the thing with renal reserve, we have a lot of reserve. Like we have a lot of, if you have a large portion of your kidney functioning, you can still be okay and not have any symptoms. Renal insufficiency is where the glomerular filtration rate is decreased to about 20% of normal. So you could lose 80% of your function and still not really have any symptoms, which is interesting. Once you get down to about 20% GFR, it's significant retention of nitrogen waste. You're not getting rid of that. You excrete large volumes of dilute urine. So it starts out as excreting large volumes, and then it goes to excreting less. Decreased erythropoiesis, so you're going to have decreased red blood cell function, and elevated blood pressure. End-stage renal failure, you have a negligible glomerular filtration rate, so you're barely filtering. Fluid electrolyte wastes are retained in the body. Azotemia is abnormally high levels of nitrogen-containing compounds in the blood. Anemia and acidosis. So it's the 3 A's of end-stage renal failure: azotemia, anemia, and acidosis. All of your body systems are affected because your kidneys affect all of your body systems. You have marked oliguria and anuria, which means decreased urine volume and sometimes no urine volume. Regular dialysis or kidney transplantation is needed to maintain the patient's life. So end-stage renal failure is serious, serious stuff. So the early stages of chronic renal failure, you have increased urinary output because we had that renal insufficiency. General signs of anorexia, nausea, anemia, fatigue, those all sound familiar for a lot of other things, right? Unintended weight loss, what's going on? Exercise intolerance. So early on, we don't know what's going on. These symptoms are vague. Then we start getting into bone marrow depression and impaired cell function caused by increased waste and altered blood chemistry and elevated blood pressure. So the signs are just so vague, it's really hard to diagnose early on. In the final stages, you get decreased urinary output, oliguria, dry pruritic, which is itchy, hyperpigmented skin and easy bruising, peripheral neuropathy, impotence in men and menstrual irregularities in women, encephalopathy, congestive heart failure or dysrhythmias, failure to activate vitamin D, possible uremic frost on the skin, and that's what this is a picture of, and high risk of systemic infections. So the final stages of renal failure are not a pretty picture. So this is the comparison of acute and chronic renal failure from the book, and it compares causes. Onset is acute is sudden and acute, and chronic is slow and insidious, hence the definitions. Acute renal failure, you get decreased urine output and increased serum urea. In chronic renal failure, early on, you get dilute urine with increased output and anemia, fatigue, and hypertension. With acute renal failure, when you progress on, you get increasing urine output with recovery because your kidneys are working again. If you have prolonged failure, you get that uremia, where you have urea in the blood. At end-stage failure, you get uremia as a progressive sign, and you get oliguria, which is decreased urine output, acidosis, and azotemia, which is the nitrogen compounds in the blood. So it's almost the opposite. The early stages with acute renal failure, you get less output early on. With chronic renal failure, you get more output earlier on. So it's interesting. So what do we do in PT with these people? So the primary physical therapy goals in this patient population are similar to those of other patients in the acute care setting. So the goals are to optimize safe functional mobility, to maximize activity tolerance and endurance, and to prevent postoperative pulmonary complications. So this picture, the person's using an incentive spirometer to make sure they're keeping their lung capacity up and getting any gunk out of their system that needs to be coughed up. And a lot of times in acute care, we are coaching people on how to use their incentive spirometer. So the incentive spirometer is you're trying to breathe in as slowly and evenly as possible, and the piston rises with each deep breath. The incentive part of it is you can move the little arrow up to increase the volume for their incentive. So usually after surgery, we want people to use the incentive spirometer like once an hour. So a lot. So every time I'm in the room for the PT session, I say, when was the last time you used your spirometer? And they go, oh, I haven't done it this hour. Let's do it. And I check their performance on how they're doing it and can give them tips on doing it better. So the inability to regulate cellular waste products, blood volume, and electrolyte levels can result in mental status changes because of the buildup of chemicals in the body. So you might need to modify or deter physical therapy if they have a change in mental status, particularly educational activities like teaching them how to use the incentive spirometer, or any activity that requires concentration. So disruption of excitable tissues like peripheral nerves and skeletal, cardiac, and smooth muscle from altered level of electrolytes can be a contraindication to exercise. So we may need to reduce exercise intensity during muscle strengthening activities. If peripheral neuropathy results in sensory deficits, then we need to take the appropriate precautions with use of modalities or protective mechanisms to avoid skin breakdown. So if you have peripheral or pulmonary edema from the inability to excrete excess body fluids, that can result, pulmonary edema can result in shortness of breath with activities and recumbent positioning. So we may need to educate people on positioning. Peripheral edema can result in range of motion limitations and skin breakdown. So positioning is super, super important. Fluid and electrolyte imbalance can also alter the hemodynamic responses to activity. So we have to carefully monitor their vital signs and carefully monitor their symptoms during any kind of exercise or therapy.